What should I do if someone I know is thinking about harming themselves or taking their own life? It's an important question for all of us to ask, and one we hope to provide some practical answers for in our conversation today with Dr. Yates, Conwell, and Anteprecht. Thank you both for being with us today.
Thank
Thank
you.
you.
And getting involved to help someone who might be suicidal can be a rather scary prospect for anyone. Talk, if you would, about the importance of doing so.
Absolutely. Absolutely. And I want to underscore again how uncomfortable these conversations can be and how scary it is to be a friend, a parent, a teacher, a healthcare provider, and have that worry that you're sitting with somebody who might be experiencing suicidal thoughts or is at risk for making an attempt on their life. It is uncomfortable for us to talk about. And maybe it's our own histories, maybe it's our own lack of exposure or lack of skill. Maybe it's the myth that if I talk about this, the person is going to become more suicidal. For some people, it's, oh, if I ask about this, if I talk about this, and they tell me that they are at risk, oh God, I'm going to have to do something and I don't know what to do. And for a lot of people I know, that might even prevent them from asking the question. And if that is something that people struggle with, we need help. We can't be in this alone. That communicating about suicide with somebody who might be actively engaging in suicidal thinking is something we need support in. So whether that's a team member, whether that's a spouse, somebody in it with us, and talking about it is the first thing, right? That when we talk with people, we want them to tell us more. We want to communicate that we are available, we're interested, we can tolerate hearing the kinds of pain that they're in, and maybe they feel profoundly isolated in experiencing. And we are able to sit with them and talk about it. And so I think just coming back to the importance of asking the question, being neutral and compassionate, interested, and being able to say, I want to figure this out with you. We're going to do what's needed. And so I think that is the foundation that we come from of opening the conversation, starting to allow the expression so that we know what we're dealing with. And then we can take the next steps of getting their therapist involved or calling 911 if needed, whatever the case may be.
Yates, we are working in as many audience questions as we can today. And I think the way that this question is phrased is a perfect next question for this discussion. Someone asked us the following: is there a scientific and effective method to dissuade someone from thinking of taking their own life, or do we just have to use our intuition to the best of our abilities to do so? I love that non-healthcare professionals want to do their very best to support someone in this way. What should we do if we encounter someone who is actively suicidal?
I think, Anna, you put this beautifully, that it is a very scary thing. And step one is to acknowledge for ourselves when they're in that situation that it is anxiety provoking, and to be able and work hard to put that aside and to be available. Our approach wouldn't be to adopt the posture that we're there to persuade them not to take their own lives.
Yeah.
Rather to listen, which is an extraordinarily powerful intervention in and of itself. Simply to communicate that you're interested and you can bear hearing about their pain. We don't want to be drawn into trying to solve the problem for them, but to help them realize that there are opportunities available and help that can result in their pain being managed. So it's listening, it's communicating that you care, it's uh, attempting to understand the source of their intolerable pain and helping them, encouraging them to find solutions with help from other people, and then being there in the longer run. There's a follow-up to that, which is checking in, being available, and remaining concerned at communicating this wasn't a one-off kind of conversation here. We're in this together, as Anna said.
And that word connection is so key. We're talking about the risk factor of disconnection and isolation and withdrawal, and the protective factor. One of the pieces that we want to weave in when somebody is at risk is more connection, more community, bringing them out of the withdrawal into the relationships, whatever they may be.
A viewer would like me to ask you this. In a suicide-focused training, it was suggested that we not ask if someone feels safe or unsafe. However, I have also been told that it is okay to ask this question. Is there a particular way that we should be asking someone how they are feeling about their current mindset?
Well, clearly this person is getting mixed messages because I think there are mixed beliefs out there. I mean, for me, when I'm coaching parents about their teenagers, I tend to veer away from it because what does safe mean? Like safe might be a shorthand, and it's a yes or no question, and it feels a little too. Are you safe? Yes, good. Okay, move on. Like it just, for me, I don't know what safe or unsafe mean. I want more detail. I want to lean in with more curiosity. I want more information than yes or no. Personally.
That's absolutely, yeah. It's one of those questions that, are you safe? That probably reflects more about our need to know that we don't need to worry about them because it makes us anxious to do that and scared. And, that's a human reaction. That's real. At the same time, as you go down, and in particular, more for the mental health provider or other professional working with the person, as you go down that road of trying to understand the severity or risk associated with the person's thoughts, then I'm not sure we talked as much as maybe we should about why people don't kill themselves, the protective factors, sorry, that people have. And so there's this notion of how much press there is for the person to act on suicidal thoughts. And that's important to weigh as well. And then to go on, even to ask, are you likely to take your own life before you see me next time? Not taking that as any kind of contract. Anna, you might want to comment on suicide contracting as a therapist, which is a problem, I think. But then beyond that, to be able to weigh the ability of the person to think about alternatives to ending their life and how safe they can feel. It's not our job to make us feel safe, but rather to understand if they can mobilize the resources when leaving your office, when they're back in their potentially very stressful circumstances, they can look at alternative ways to manage that stress besides taking their own life.
These tough conversations can be even tougher when we're talking about members of our own family. Any special considerations when it comes to speaking to a relative about these issues and their own state of mental health?
It is tougher because we have our own history with them, our own relationship, our own emotions about them and about the pain that they're in. But I think the guidance that we're talking about today remains the same, which is validating, compassionate, caring, availability, and openness to hearing really difficult and painful things from those we love.
Yates, any additional thoughts on that front with family?
There's a beautiful vignette on the American Foundation for Suicide website called "Talking Away the Dark," in which there's an older man, and it's a very short video, several minutes, about the interactions between them, in which his daughter becomes increasingly concerned about his withdrawal, his hopelessness, and finds a way to connect with him. It's important for us to recognize that not all family relationships are good and supportive and understanding, and not everybody has that benefit, but most do. That fundamentally there's a connection there, that perhaps it's frayed or lost, but if there's a way to reestablish that connection, can perhaps even more quickly lead to the kind of conversation that would be life-saving for the person. So it's complicated. There's a very special set of relationships, though, and that's definitely worth paying attention to if you're a family member and you have concerns. If there's a red flag that's gone up, try to figure out how to understand what's going on there and take it seriously.
And I'm thinking about parents too, and the terror that parents experience when their child is suicidal or has a history of suicide attempts, that they have their own emotions that get so powerfully overwhelming. And sometimes they experience symptoms of PTSD themselves from their child's suicide attempts in the past. And they need support. I mean, certainly they're in front of their kids every day, and the kid might be in therapy. And oftentimes I recommend parents get their own support, their own coaching, so that they can respond in a way that is balanced and most helpful to their kids.
Yeah, in the wake of that response, Anna, let me have a follow-up with you here, if I might. Following a suicide, I'm sorry, how do you suggest that we ask how a child or teen is feeling about thoughts of self-harm or thoughts of harming others? Any specific suggestions?
I mean, it's hard to say, because I think parents know their kids and the language with which to ask, right? And sometimes it's as direct as that. Hey, are you thinking about this? And it might be at home in the living room, right, when there's music on. And for other kids, it might be we're playing a game of catch, and that's the time to catch them, literally. But be able to find the moment where you're going to get the most accurate and genuine response. Because with teens, the relationship really has to be there. And timing is key. You're not going to ask them this when you're on the car ride for them to take, a calculus exam at school that they're freaking out about, right? And so it's figuring out timing and when that connection is there for more authenticity. And the wording, I think, matters a bit less than the question being asked.
Let me ask you about a clinician's perspective on all of this and what they need to know. What if a patient tells me that they are fine, but I believe that they are struggling and may be at risk for suicide? What are the next steps for that clinician?
Well, I think if that clinician were coming to me for supervision, I might say, can you articulate what it is that you're observing that's leading you to think they're not fine? Right? Like, get descriptive. I don't want it to just be my spidey sense says, like, you're picking up on something. And so notice what those things are. And again, working with teenagers and young adults, as I do, I get fine up, down, and around the block every day. And oftentimes my first response is, actually, are you? Because I'm noticing that your shoulders are hunched and it looks like you didn't brush your hair today. And I know that you were struggling a couple of days ago after you had a fight with your boyfriend. And so I kind of lean in. I don't just accept the fine. And that's contingent on the relationship too. right? That I build upon that with more interest. Like, hang on, I'm not quite sure. Are you sure about this? Because sometimes people say they're fine when they're not. And when people say that they're fine and they're not, and people just dismiss it, it leads to that person feeling more misunderstood and more disconnected, right? So leaning in. And if somebody says to me, nope, I'm fine, I don't want to talk about it, nope, I'm fine, then I'll say, okay, I'm here, I'm worried about you, and depending on the level of my worry, I might come up with a plan for reconnecting.
We have a lot more questions regarding these difficult conversations, and we'll get back to them. I do want to ask you both about de-escalating an immediate crisis. First of all, what is the difference between actively being suicidal and having had thoughts of suicide?
We were talking a bit before about how that discussion goes to understand what the person's risk is at the moment. And so there's other data that back this up, right? And we talked about, does the person have a prior history of suicide attempts? Is there a family history? Has the person experienced immediate and chronic stressors that represent increased risk? So with that background and the kind of sense that we're just discussing, that the person's raising concerns for you, one enters into that discussion to get more information about their current state and the nature of their thoughts. And our job in the professional arena, that's our job, is to tease that stuff out and to be strong and non-judgmental and communicate caring by asking the tough questions in a systematic kind of way. Have you had thoughts that your life is no longer worth living? Have you had thoughts of taking your own life? Using the suicide term very directly, often, depending on their cultural background, how you get there. Have you had thoughts of what you might do to take your own life? What would you do? Do you have a gun in the home? Have you thought about other methods that you might use? And that gets into important conversations about other methods and access to those lethal means, like stockpiling medications, access to other kinds of potentially deadly means. What have you been thinking about? Have you actually practiced that at all? Because practice takes it to another level. You know, the rehearsal. Yeah, I took out my gun and I loaded it. Actually, that's a different ballgame than there's a gun somewhere in a trunk in the attic. And then moving on from there up that level of potential lethality of intent and implementation that we need to know about to make those decisions. I'd want to just be real clear that if we are concerned that the person's unable to engage with us, if there's something going on that you just simply aren't able to break through, then sometimes that might be the indication for you to make another contact, to, with the person's permission, contact a family member and get additional information about what they've observed. And even understanding that under some rare but critically important circumstances, intervening by having somebody go to an emergency room, for example, can save a life. And that's part of what we, again, in this mental health professional arena, need to be prepared to do.
And on that specific point, if it is clear that a crisis is imminent, at what point does a family member, for example, pick up the phone and call 911 or make a call to 988? And any guidance on that front?
Well, I mean, I think if the crisis is imminent, they pick up the phone and they call, absolutely. And 988, I love that this is now a resource. I especially love that texting is an option with 988, because not just with my peer group who is now leaning towards texting more, but especially with younger adults and with teenagers, they are much more likely to engage in a conversation. And 911, if a family is saying, like, I'm worried that something is like, this is imminent. And when I think of imminent, I'm thinking really like imminent, then calling 911. What's the harm, right? Worst case scenario, somebody shows up and says, okay, this is not a risk. And you might save a life, get the person the treatment that they need.
It had context, and the 988, I think, is such a fabulous advance by the United States to make that available to people nationwide. And people need to understand that these are professionals on the other end of that line who are really, really good at doing all of the things, by and large, that we've been talking about here today. And that built into that fabric of systems are people with special expertise in certain areas. So you dial 988 if you're a veteran, you can hit 1 and speak to the Veterans Crisis Line. If you're a person struggling with LGBTQ identity and issues that stem from that, then the Trevor Project has very skilled people available in the same kind of way in a nationwide network. So we should get comfortable with using that as a supportive resource that is critically important and life-saving in these circumstances.
Let me shift gears here briefly and talk a little bit about safety planning. This is something that we hear often in the conversation about suicide prevention. What is a safety plan and how does it work? Anna, you want to start us off on that?
Well, a safety plan, ideally, I mean, when a clinician, when a provider is meeting with an individual and they're reporting suicidal thoughts, the safety plan, or in the parlance of DBT, the skills plan, the cope ahead plan might be, what are you going to do should these thoughts arise in a couple of days? I know that you've got this event coming up and it's going to be stressful. And I know that sometimes when your stress gets to a certain place, that your mind goes down that path because it doesn't know what else to do. Let's talk about what else you're going to do. And so creating that toolkit of how to manage it. And for some clinicians, part of that toolkit might be getting a phone call and doing some coaching or doing a check-in with their client in the heat of the moment. But it's rehearsing more skillful alternatives and kind of like steering the brain into a more balanced place. Okay, so if your emotions get to whatever it might be, an 8 out of 10 or a 7 out of 10, what are you going to practice? And we practice these kinds of things repeatedly to get that path more worn so that it's more likely to be walked in the future. So, all right, you're going to call your friend. You're going to look at pictures of cute puppies on YouTube. Like, what can you do? You're going to take a cold shower. You're going to go for a run, and having that kind of safety plan, but also making sure it's involving connecting with others. Because when people are experiencing suicidal thoughts and they get into it themselves, I don't know that they're going to go for a run as part of their safety plan. Right? Reaching out and connecting with supports that they have identified. It's my sister, it's my best friend, it's my therapist, and having those numbers handy so that in the heat of the moment, it's more likely to be used.
Question from a viewer. How do you motivate a client to contribute to the creation of a safety plan when feelings of hopelessness are overwhelming them? I'm assuming this is coming from a clinician.
Well, it's going to be hard to get somebody on board with creating a safety plan, whatever we might call it, when they are in the throes of hopelessness, because why bother, right? That's going to be tough. You can create it so that it's maybe in front of them, but the buy-in to use it is going to come from those moments when they're a little more in a collaborative, willing space. Maybe the hopelessness is a little less intense, and you're going to do it then. I mean, of course, create the plan, come up with a plan for how to go about the week and identify what the potential risky times might be and what somebody might do. And then I think you're going to hopefully build that plan across time.
Yates, here's an important question that came in. Following a suicide attempt, are we ever able to feel as if that person's struggles are behind them, or should we always be vigilant in terms of checking in with them?
Yeah, that's a great question, and like so many others in this, has two sides. I think it's natural and almost the rule that once a loved one has attempted suicide and that has an impact on you, then to put that away somewhere and just not worry about it is very hard, impossible to do, and not necessarily the right thing even to try to do. To be at the same time use that as background education, helping understand one's own reaction to the distress of a loved one is important to do, but also to recognize that people do grow and they do learn from prior experiences of a suicide attempt or having been suicidal. We are, as helping providers, learning so much from people with so-called lived experience. And there are many, many of us out there who have been through crises and even had these thoughts. And to recognize and honor the growth that can happen as a consequence of having been through a crisis like that can be important as well. Not to be overly sensitized to the downsides, but to recognize that that person can grow and actually develop additional strengths of having been through a suicidal crisis before. Anna, can you help flesh that out?
Absolutely. Well, and again, we're talking about flexibility, right? Because of course we don't want to swing to the side of, okay, well, they're fine and that's it, and they're done with that. And I see families all the time who are walking on eggshells, checking on their children while they're sleeping to make sure that they're safe, and asking all the time out of the terror that it's going to happen again. It's going to happen right now. And I've got to stay on top of this with a sense of vigilance, right? And so the space in between is really allowing for that growth, being available and supportive and open to hearing about struggles that may emerge again.
It's interesting. A separate question came in, which is very related, and the word autonomy plays a key role in this. Can you speak to the balance of working to encourage a sense of autonomy while maintaining safety in someone following a suicide attempt? Could one of you speak to that particular issue of autonomy?
This is a tough one because of our own emotions, our fear, right? We don't want to leave people alone. We worry. We're terrified as parents, friends, siblings, children, whatever it might be, that it's going to happen again. And allowing for some autonomy does feel important because people are not the sum of that moment where maybe they acted in a suicidal way, right? We cannot say that's who you are forever now, right? And so I think it's got to be a communication issue of, all right, you want to go to the store and I've got this worry. How do we make sure that this is done in a way that's balanced and isn't risky? I'm going to ask you about your level of suicidal thoughts at this moment.
There's another word that might be useful here to acknowledge, and that's responsibility. Mm-hmm. That some of the best, most successful approaches to an intervention, psychotherapeutic intervention, really are based on the notion of connection and collaboration between the patient and the therapist, for example, but it applies in any kind of relationship that's supportive. And that's to acknowledge simultaneously that I'm here to help you, but also you have a responsibility to work with me to manage these things in your life. And I think you can do it well and better. So that we both have a shared responsibility to move forward and find a way to recognize your strengths, for you to utilize my support in any way that can be most helpful to you. It's not exactly autonomy altogether, right? Which suggests more leaving that person to manage it themselves, as opposed to be responsible to manage it with all the resources that we can help you obtain.
So many questions coming in for you too. Let me work in a couple more here. I work in hospice, which is a difficult space for those who are experiencing suicidal thoughts and cannot see any other outcome. I often try to reframe the focus on family/loved ones, but I feel like we can do better for these folks. Any suggestions?
Well, it's a systematic, sort of diagnostic approach in some respects. I mean, there's so much going on there that can be remediable or partially remediable. Again, it's that notion of the ambivalence, and that one of the initial responsibilities that we have in that environment as helping professionals is to sort out what's driving that, what's the source of that intolerable pain. And there's a lot going on in a hospice setting that can contribute to that. It can be biological factors of what is the illness impact on cognitive function and the ability to think creatively about alternative or value other kinds of interventions. It can be the medications that people may be getting. It can be the pain associated with the illness. It can be something about physical function or disfigurement or so on. And equally likely, or perhaps more so, the impact that the loss of being in a hospice suggests to family relationships and access to support. Each of those we have potentially a different approach to managing. So we need to start by simply understanding what's behind that. What's the driver of making you feel that way? Because it's not as simple as say, well, I've got cancer, I'm on hospice, and I'm going to die. There's a grieving absolutely always associated with that, but even that is a multifactorial process that if we can tease that apart, be supportive for what is the driver, what are the drivers, likely more than one, then that's when we can be most helpful in that circumstance.
Another specific question about a work environment. I work in an emergency room doing assessments. As a sibling survivor of suicide, I want to do better for my patients during the 10 to 15 minutes that we have together. Any tips for things that I can do during my brief assessment to get them to connect with me despite having just met me?
Oh, that's a tough time window in a really tough environment with a tough job. And my heart goes out to this person with this experience in their personal life doing this kind of work. But I think it is showing up and trying to connect with warmth and validation, all of the things that we've said to reduce the acuity of the stress and maybe the fear of being in that environment, and try to connect in a genuine way as much as possible.
Let me ask you a little bit more about safety planning and questions that have come in terms of how do we get one of those in place? Are there resources out there that both clinicians might turn to and family members themselves?
Absolutely. I mean, these are available online, and there's 100 different worksheets and ways that we can do. I don't think there is one standard, although they have a lot of commonalities about identifying emotions and risk, and then the plan for what to do next, which includes many of the things I said. But I think many clinicians make up their own worksheets, but I don't have a standard one that I use unilaterally.
As I was saying it's an evidence-based practice, and there's clearly evidence that doing safety planning in a systematic way, going through all of those typically 6 steps that you're referring to, reduces the likelihood of repeat attempts, for example. It's been most fully tested in emergency room settings. We use it in our emergency room. We use it in our inpatient settings prior to discharge. And it can be updated on a regular basis. But yeah, go online, search suicide safety planning, and you'll find actually a lot of different references there on how to do this.
We have focused much of this discussion so far on suicidality, broadly speaking here. What about non-lethal self-harming in terms of interventions and an approach to having those difficult conversations, perhaps with a teen child about what is happening on that front? Can you shed some light on the best process for that?
The principles are the same. It's going with interest and curiosity. I'm noticing that there are cuts on your arms. What's going on? What are you struggling with? Right? Approaching it with compassion, with care, asking the questions, not being afraid to ask because the other person might get angry or defensive or be embarrassed, but communicating, I'm seeing this and I'm worried and I'm here and I want to help because this is an indication that there's something else going on.
Yates, anything you want to add to that?
I don't think so. We see that so less often in adults and older people than in adolescents and kids. So I have nothing.
And I mean, for parents who might say, all right, I'm going to take you to the therapist, right? That's harder to do with your adult kid or maybe with your parent, but we're going to go meet somebody. You know, that you're 14 years old and I'm worried and I take you to the pediatrician, I'm going to take you to the psychologist. And then I'm going to educate myself and read some books and identify what this is all about to be able to respond more effectively.
And as it relates to the notion we were talking about before of passive suicidal ideation or behaviors that are really very indirect and hard to examine, it's the same approach. I'm noticing that you're not taking care of yourself quite the way you did before. What's going on? That I'm worried about you, and then go from there.
We have tackled over the past 45 minutes or so a number of questions specifically about clinicians and suicidality and about family members. Let's talk a little bit about the intersection of those two worlds. To what degree is communication key between a family member, for example, and clinicians when we're talking about a younger individual and suicidality?
In my world, it's absolutely key. It is crucial that when I have a 14, 15-year-old sitting with me and we're doing some work to reduce, say, non-suicidal self-harm or suicidal thinking, I've got to have the parents in the loop of what's going on. I'm not going to say, here's everything that happened in our session or every thought I have about your kid. And I want them to know in an education kind of way what's going on. And parents need support. Parents need their own skills to manage their emotions, to respond to their kid in a different way as their teenager might be acquiring the skills to manage their own emotions. We want to make sure that the home environment is supportive of that growth, because the kid can come to me all day and learn how to do things differently. And if they go home and are getting problematic responses or those skills are getting blocked, there's not going to be the same movement. And so the parents need skills too. And so that communication absolutely is key.
And with adults, of course, it's somewhat more complex because the adult or the over 18 adolescent, young adult, has the right to say, no, I don't want you to be talking with my parents or siblings or anybody for that matter. And then we need to work with that. We need to understand their autonomy in that sense, but also to help understand what's behind that, because there's a signal there that they're having trouble asking for help or knowing how to reach out. And there might be a lot of information we need to understand with that. The boundary there, of course, and it's critical to understand, is that if then you as the clinician have a concern about the patient being at imminent risk and reaching out to help avert a self-destructive act or a suicide to other people, and thereby, quote, break confidentiality, unquote, then that's your obligation to do that. So that's the circumstance. If a parent calls you about a young adult and says, tell me what's going on there, then without the patient's permission, I can't do that. On the other hand, I can listen to what they have to tell me. That's fine and really important to do. And then to build a relationship that enables that kind of communication, which can be so critical, often is, perhaps always, to finding the right solution.
And when adults are refusing to allow that communication, the work is to then help them see the wisdom, right? Whether it's giving permission for me to talk with their adult child, right? There is wisdom in this, and we need to make sure that they can see how this can benefit them longer term.
You two have both been doing this work for a lot of years, and I'm really curious to hear from both of you what you think about the current trend line. Is awareness becoming more prevalent in terms of how to intervene in these critical moments? Are there systemic policies in place and resources in place that are giving you encouragement in terms of addressing these issues? What have you seen over the years that you've been doing this work? Anna, I'll start with you.
Sure. As we've said a few different times, hope is possible, and I am hopeful. And we're having this conversation today, right? And that indicates to me that people want to learn about this. They're open to having the conversation. 988 is now an available resource, and it wasn't 20 years ago. So I do see indicators here and there that people are more open to having the conversation and hopefully shifting this trend.
Yates?
Yeah, I was thinking the same. By and large, 988 being one really, really important, terrific example. Elsewhere, and this gets much more controversial even, would be the uptake of red flag laws or extreme risk protection order legislation in some states, including New York, my own, in which one can petition under certain highly regulated circumstances for firearms, for example, or access to means be removed from another person's home. Very, very complicated decision that requires our weighing autonomy and therapeutic alliance on the one hand with safety on the other. But that's our job, to figure out how to do that and when. Speaking about other controversial, complex issues that I think loom on the horizon in later life is the spread of medical assistance in dying legislation, for example. And there's reasons to be concerned about how our obligations to older adults to understand what drives suicidal thoughts and how that's distinct from other kinds of thoughts that drive an interest in early termination of one's life, are where they're coming from and where they're going, rather than make that purely a legislative kind of decision. And I appreciate how tremendously complicated and controversial that is, and respect a wide range of opinions on it. But as another example of the ways we need to be alert to what the cultural attitudes are towards suicide, for example, and where there may be universal preventive intervention approaches that are tolerable at the right time and the right place from others. Overall, I think there's some action that we're thinking more in a more comprehensive and sophisticated way about these issues than was the case before, and opening up new opportunities.
Anna and Yates, I'm afraid we have run out of time for the session. I want to thank you both for sharing your time and your expertise with us. You are both doing such important work. Thank you.